Yeah. So, Dr. Rachel Stovall is a pneumatologist at the University of Washington whose research focused on improving outcomes for patients with axial spondyloarthritis. She completed her medical school at the University of Washington, internal medicine residency at Boston University Medical Center, and fellowship at the University of California, San Francisco, before returning to the University of Washington as faculty. So, it's all yours.
Great. Thank you so much, Jen, for the introduction. It's really nice to meet you all, and I'm excited I get to talk about one of my favorite topics. I hope that you'll all enjoy it, which is about how we can improve outcomes for patients with particular focus on addressing sex differences. Long story short, I don't have all the answers, but I want to kind of show you what we've been learning and exploring so far. I don't have any financial disclosures or conflicts of interest. Maybe some things that are interesting about me is that the SAA has actually given me some funding, so I'm very grateful. They gave me an Early Career Investigator Award. I'm also a member of Spartan, which is the Spondyloarthritis Research and Treatment Network. And then I am on the voting panel for the latest American College of Rheumatology treatment guidelines for spondyloarthritis. So we're actually revising the treatment guidelines right now. Not sure if you all know, but the last time we did that was 2019. So there's a lot of data to go through. So next year it should be pretty exciting when we have new guidelines. So I'd like to start with some background about what we know about sex differences in spondyloarthritis, and then I'll go through the research that I've done that's already published, what I'm doing currently, and what's submitted, and kind of like what are the next steps. So, as you all know here, I don't have to tell you that axial spondyloarthritis is a chronic inflammatory disease that primarily affects the axial spine. We know that some patients can get peripheral involvement too outside of the spine, and some people get other manifestations too, even outside of the joints. So, uveitis, inflammation of the eye, psoriasis, inflammatory bowel disease. And historically, we thought this was a disease that predominantly affected men between men and women with this condition. Um, and sex and gender do influence the manifestations and outcomes of patients. And we're still learning about this right now. So, a couple of years ago, I wrote this review article on sex differences in spondyloarthritis. And if people are interested in this, I can send it to Jen and she can email it out to the group. But I worked with Dr. Leanne Gensler on this. She's an expert in spondyloarthritis from the University of California, San Francisco, where I was doing my fellowship. And so I thought maybe I'd start by sharing some key concepts from this review and then talk about how it inspired the research I do now. So I'm going to illustrate some of the differences here, thinking anatomically and physiologically, like how men and women are different and how that could impact symptoms and also even treatment response. So first, just talking about anatomic differences, I'm showing you two x-rays here of the pelvis, so a female pelvis and a male pelvis. You can see that women tend to have this wider pelvic outlet and this broader oval-shaped pubic arch, whereas for men, there's more of this kind of heart-shaped narrow sacrum. And this can lead to different loading on the spine. There are some studies to show that women are more likely to get injured because of that different spinal loading. And something else interesting too is that women, after they've been pregnant, that can also put a lot of stress on the sacroiliac joints in the spine and can cause different conditions as well. That's outside of spondyloarthritis. Oops, sorry, I keep going ahead. So women, other things, so women tend to have smaller kidneys and livers compared to men, which means that they may eliminate drugs slower and may be more likely to have adverse events from drugs. And then thinking about the gastrointestinal system, women have a slower transit time. They also have more fat mass than men. And so all of that can influence drug metabolism too. So these are just kind of arguments for why we probably should be thinking about men and women a little bit differently. We don't know exactly how hormones influence this disease. It's interesting in other conditions like rheumatoid arthritis, there seems to be more of a female predominance, and people sort of hypothesize maybe it's because of like the estrogen effect, because we don't see that same female predominance in postmenopausal women and older men, but that doesn't apply in spondyloarthritis because half of patients are men, half are women. And so we don't know how hormones influence this disease. But we do think that probably at transition points like puberty and menopause, those probably do affect disease activity. And then in terms of immune response, men are more vulnerable to infection and women are in general more prone to autoimmune disease, which is kind of interesting. When we think about pain processing and sex differences, women tend to have a higher density of pain receptors in the skin, so they can feel more pain. Women have less of these opioid receptors, so they may have a different response to opioids. And then having more testosterone, which males have, could increase pain threshold. So there could be a different experience of pain between men and women. So when we compare different manifestations of axial spondyloarthritis by sex, so here are some of the things that we talk about in the review article. So women may present with more widespread and peripheral pain, so meaning pain outside of the spine, whereas men may have this classic low back pain, which is kind of the way that we talk about spondyloarthritis in like a medical textbook. I understand these are all generalizations though, and so everyone's going to have a different experience, but this is sort of looking at data at a big picture global level. There is unfortunately a very long delay to diagnosis in spondyloarthritis. And for women, it can be twice as long. So all of this is just too long. So, for men, we say the median delay could be 5 to 7 years. For women, it can be 9 to 14. And I think that could be because, presentation is different, but also because of these other things I'm listing here. So maybe some of you are familiar with this blood test called a C-reactive protein. This is a marker for acute inflammation. And we can use this test when we're trying to figure out, does someone have spondyloarthritis? Like it could be a marker of active inflammation, but it's more commonly normal in women compared to men. So that can kind of confuse people too. I already mentioned that women can get more peripheral arthritis compared to men. They also can get more enthesitis. That's inflammation where ligaments or tendons connect to bone. In terms of the extramusculoskeletal manifestations, so those are similar in men and women. So that's like uveitis that we talked about, inflammatory bowel disease, and psoriasis. Um, and then here, this is another issue with diagnosis is that women are less likely to have radiographic damage compared to men. So typically what should happen is that if someone was concerned about spondyloarthritis, you get an x-ray of the pelvis first. For some reason, we don't know why, but men are more likely to have abnormalities in the sacroiliac joints on their x-ray. Whereas women, we have to more commonly get an MRI to see inflammation and chronic damage from axSpA. So it was really with the advent of MRI that we found out actually women are half of patients. Something that I'll talk more about my research, I noticed when writing this review article, there were a lot of papers talking about functional outcomes, and women reported worse patient-reported outcomes and greater functional impairment. So we'll talk more about that later, but that was sort of like a stepping stone for me when I was writing this review article. I said, oh, I want to dig more into that because most studies were just done in Europe. See, I'm admitting somebody to the room. Comorbidity, so men tend vascular morbidity and mortality compared to women. I think that's kind of similar to the general population too, where men are more likely to have earlier heart disease. And then lastly, fibromyalgia. So this is something that's more common in women. It's associated with widespread pain. This is a condition you may have heard of. It's kind of like where the brain is interpreting pain when there's not chronic damage happening. It's kind of like a widespread pain syndrome. And so that's more common in women too. And that can confuse doctors and it makes them think sometimes less about spondyloarthritis, but they shouldn't. They should still consider it. All right. So um, another thing that we talk about in the Sex Differences article is treatment discontinuation. Something that I thought was really fascinating is that multiple studies have shown women stop TNF. So TNF inhibitors are medicines like etanercept, which is Enbrel, adalimumab, which is Humira, infliximab, Remicade. And so multiple studies have shown this, and we don't know why. I did mention that women are more likely to have adverse drug events. So it's possible that women are stopping these medicines sooner because maybe they have like an allergic reaction, for example. I definitely see that in my clinic where women are more likely to have injection site reactions. So I can kind of say that's my experience. Um, some of these medicines like adalimumab and infliximab, people can develop antibodies. So their body can become resistant to the medicine. So over time, a patient might say, gosh, it was working before and then it stopped working. It's because they developed antibodies. So we can actually prove that with a blood test. And women tend to be more likely to have that resistance to the drug. Um, Maybe just women in general, like I mentioned, are more likely to get different kinds of autoimmune diseases. So that could be linked. Other reasons why we think maybe women discontinue the medicines earlier again is like if they're also, they have inflammation in the spine, but they also have a lot of peripheral pain. Maybe we're not, treating that symptom burden. Maybe there's a fibromyalgia component too. So there's so much to explore here. We have other drugs, other mechanisms like IL-17 and JAK inhibitors. So in terms of IL-17, you may have heard of secukinumab, which is Cosentyx, or ixekizumab, which is Taltz. The JAK inhibitors, we have upadacitinib, tofacitinib, and we don't know much about these medications and their discontinuation rates by sex. So this slide is kind of like a teaser slide, but later this month at the American College of Rheumatology conference, we actually got an oral presentation to talk about our research and sex differences in medication discontinuation. And we looked at all those drug classes. So that's just something kind of for the future. It has to be presented at ACR first, but just to kind of let you know that we are exploring treatment differences by sex. And we want to know why men and women are responding differently. So that way we can, choose. So, kind of summarizing this first part of my talk, we know that sex and gender have important roles in the disease and spondyloarthritis. They contribute to different manifestations, response to therapy, and also outcomes. We know now that half of patients with spondyloarthritis are men, half are women, and we used to falsely think that it was only a condition that affected men. And, it's important to keep in mind that people have assessing this diagnosis in the clinical setting. So I think, we probably need to do a better job teaching primary care doctors so they know when to refer to a rheumatologist so we can give everyone an earlier diagnosis. So this is something that a lot of people are working on. I know at Spartan, for example, they're making new referral guidelines to help primary care doctors. So they can say, like, what are the clues that should make us refer this patient with back pain to a rheumatologist? And so we think anatomical, physiological, and hormonal differences can account for the differences we're seeing in XSPA manifestations. And so clearly more research is done. And so this is an area of spondyloarthritis research that I'm really interested in contributing to. So that brings me to this study that we published last year. So like I mentioned, when I was writing that review article, I was thinking more about, oh, are there really functional differences between men and women? Can we see that in the United States? Most studies had been done in Europe. And so we had an opportunity to see what's going on in the US. And so we did this large study across the United States, and we looked at the relationship between sex and functional status or functional decline among people with spondyloarthritis. And because we know from other research that income level also plays a major role in functional status and functional decline, that people with lower income, for example, they may have more medical problems, more difficulty accessing medical care. We wanted to kind of stratify by income too, to kind of look at both, what's the role of sex, what's the role of socioeconomic status and functional status. And we hypothesized that women would have worse functional outcomes compared to men, and that would be across different income levels. So to do this research, we use something called the RISE registry. It's also called the Rheumatology Informatics System for Effectiveness Registry, and it's a really wonderful data set for research and discovery. What it does is it includes data from about a third of rheumatology practices all over the United States. I'm showing you this picture here of all the included practices. And we have over 1,000 rheumatology providers and over 200 practice sites. And because everyone's using these electronic health records, we can passively collect data from these sites and put it into the RISE registry. Everything is de-identified, we clean the data, and then we're able to analyze it to improve patient care. So we included patients from the RISE registry who had a diagnosis of axial spondyloarthritis, and they also had to have this functional status measure called the MD-HAC. So I'll talk more about what that is, but basically it helped us look at function at one point in time and then the change over time to see who might be having a decline in their function. So another way of saying that, kind of like a cross-sectional study, it's like a snapshot in time versus a cohort study where we were kind of looking over that 2016 to 2022 range of dates. We also looked at people's sex, and for socioeconomic status, we had this variable called area deprivation index. It's basically a way to use someone's zip code to kind of estimate like what their income level is. So this is the MD hack. This is a survey that's used to assess function in people with different rheumatic diseases. It's a shorter survey compared to some of our other ones. So I don't know when you go to the doctor if they have you fill out any surveys like this, but this one asks you about what your abilities are in the last week. You know, were you able to do XYZ without any difficulty, with some difficulty, much difficulty, or just unable to do it all? And then we're able to get a score to really quantify people's functional abilities. So you can see some of the questions they ask is about difficulty with getting dressed, getting in and out of bed, lifting a full cup or glass to your mouth, walking outside on a flat ground, and so on. So going on to the results of our study, so we were able to identify over 5,600 patients or individuals with axial spondyloarthritis. The average age was about 54, and a little bit over half of patients were female, which is kind of like my point too, that, you know, half of patients are women. And about 70% were non-Hispanic white in the study. We did see that women had a lower functional status or functional impairment compared to men. And when we looked across different levels of income, that was really consistent. And then we looked longitudinally. So over time, as I mentioned, we had about 6 years of data, and we were able to look at about 2,300 people. You can see here on the y-axis, we're looking at the probability of functional decline, and this is going from the highest income to the lowest. So as people, if you look at people over like from high to low income, you will see that there is more and more functional decline. And then you'll see for each level of income, with males on the light blue and females on the dark blue, females always have, it looks like, a higher functional decline compared to men. And then we also looked a different way that you can't see on this graph and just sort of calculated it was significant that women have about a 1.7 times higher odds of functional decline. We do have limitations to this study. You know, I mentioned that the RISE registry is collecting data on a third of, you know, rheumatology care in the United States, but really only 20% of people in this registry with AxSpa had the functional measure that we were looking at, the MD hack. So, you know, we went from tens of thousands of patients down to like 5,000, and that's because we had pretty picky inclusion criteria. So not every rheumatologist is measuring functional status in the same way, and maybe some aren't at all. RISE also contains more community practices, not as much academic. And if I had to guess, I would say that community practices, they might have more healthy patients and academic centers might have more sick patients, but it's hard to know. I think, you know, working at the University of Washington, we see a lot of complex patients. And so that could mean that RISE is capturing like the healthier patients, and that can kind of skew our results. And then we used MD hack, which is really a general measure for functional status that's used across different rheumatic conditions. So people use it in rheumatoid arthritis, lupus, other conditions. There is a functional status measure that's just for spondyloarthritis, and that's called the BASFI. But we just didn't have enough data in RISE to study that. And again, this wasn't like a randomized controlled trial or anything like that. We were just observing data over time that already happened. We weren't actively collecting data, so there could be variables that we just couldn't measure, and so that means our study might not be capturing everything. So I would say in this large sample of people with axSpA, we were able to see that women did have worse function than men at baseline and over time. I think that was helpful to study in the United States because it hadn't been done before. And then we saw people with lower socioeconomic status also had worse function and which is something we had seen in other conditions outside of spondyloarthritis. So we want to have interventions that improve everyone's function and also kind of explore Like, what is it about, women and people lower income? Why do they have, worse functional impairment? And how can we kind of lift everybody up to help all patients? So that brings me to my current work. So I'm really interested in finding ways to improve outcomes among women and men, thinking about sex differences. How can we tailor an intervention so it works for everyone? And one way I'd like to do that is with focusing on physical activity. And so that's because exercise is one of the key recommendations for managing this condition, as you may know. It improves outcomes. I know that some people have a hard time exercising. I think that's not even just in spondyloarthritis, that's everybody, right? And the exercise trials that we have to date, either they have a male majority or they don't really separate out outcomes by sex. And so I think we need that kind of information. We don't know how women are responding to exercise interventions. I will say that there actually was one study in the UK that I thought was interesting. And they found that while women exercise less, when they did increase their exercise, they had much more improvement in their disease activity and function compared to men who were exercising at the same level. And it sort of made me think, oh, wow, like, are we really missing an opportunity here? Like, to help people exercise, maybe it'll help them feel so much better. This is just a reminder from some of our treatment guidelines. These are European guidelines from 2000 and say the same thing. Kind of like the first thing you want to do, if you can, is to give someone an NSAID unless they have a medical indication where they can't. But physical therapy is on the same line. So this is just to sort of emphasize that medication therapy equally important. So now I'm going to focus on the physical therapy and exercise component. And then here's some examples just to kind of remind you like what people are recommended to do in exercise for spondyloarthritis. And I got this from spondylitis.org. So Andrew Louis, he's a physical therapist at UCSF where I did my training. He actually created a lot of this information that's on the spondylitis.org website. And I'm working with him on my research project now. So I think, yeah, Jen, we're going to go into my current work. So maybe I'll ask if you can pause the recording.